Noma's new best friend, I guess. Dr. Halasa came on board with us about a week and a half ago. And Dr. Halasa has extensive clinical and research expertise in the field of immunotherapy, stem cell therapy, laser therapy, nanomedicine, and chronic disease prevention and management. He's earned his medical degree at Tripoli University in Tripoli, Libya in 1998 and passed here to the United States medical exams. Dr. Halasa is a researcher in immunotherapy at Baylor University in Texas and is the chief executive officer and founder of Chronic Disease Prevention and Management Centers in Hollywood, Florida. Dr. Halasa is a frequent guest speaker at renowned venues such as A4M, SPIE, ASLMS, and the Nitric Oxide Society, FAPM, and ISLA, NAALT, and Photobiology Society. And he's here to talk to us about an introduction to chronic diseases prevention and management as a new medical specialty. So, warm round of applause for Dr. Halasa.
They find out when Corona hit and the pandemic, most of the specialists failed to manage COVID-19 because COVID-19 is a multisystemic disease. And most of the specialists, they focus on one system. And that's the reason I think they end up with this new field of medicine. It's called chronic disease prevention and management. And their group, they focus more on redefining the history and physical exam. And so they came up with something that's called 360 HP, which we're going to look at what they did. And from my side of chronic disease prevention and management, I focus more on redefining the treatment and the diagnosis. So the chronic disease prevention and management is a new medical specialty that focuses on developing diagnostic and therapeutic protocols to manage and prevent chronic diseases across all medical specialties by assessing, monitoring, and modulating the immune, redox, metabolic, and regenerative status of the patient. So that's the definition of this new field of medicine. And then I was able to train a lot of doctors to adapt those protocols. Among those protocols is nanomedicine, clinical nanomedicine, which is loading drugs inside platelets nanoparticle, because that will help a lot in managing chronic disease. You want to get those medication into the pathology versus goes everywhere, especially for cancer. And we call it targeted therapy. And so I train a lot of doctors. Among those doctors are Germans. I traveled to Germany, and I have 2 clinics there. One of them, I trained them how to load drugs into platelets nanoparticle. And this is I think, the group in Germany here. I don't know how to play this.
In Germany, me and Dr. Hans, we are partnering together, and hopefully we'll have many centers in Europe. You want to say something?
Yes, he is right.
So that was my group in Germany. And also I train a couple of doctors here in Florida, in Idaho, and in New York, Dr. Joseph James, Dr. Isam Khiyata, Dr. Patel. Many of doctors, they are trained to manage chronic disease with using the protocols that they are adapting from us. And it's all based on assessing and monitoring and modulating those 4 pillars, which are the redox, immune, metabolic, and regenerative status of the patient. So that's the definition of chronic disease prevention and management. I'm talking about all chronic disease, including diabetes, cancer, cardiovascular conditions, autoimmune disorders. And so let's give an example of how we approach patient with chronic disease. So we have a case here, 48 years old, male suffering from type 2 diabetes and obesity, show persistent high blood sugar level despite receiving standard insulin, because that's what we do in the protocols of the mainstream medicine, that we give them insulin. But us, as chronic disease prevention management, we take care of the root cause. We're looking for exactly what aggravates diabetes, what triggered the diabetes, what caused insulin resistant, and then we start managing all those conditions. And so for us, it's not enough just to mask the problem and give them insulin, because when you give them insulin itself, it's a free radical generator, and it's causing more stress and more oxidative stress and more insulin resistance, and then you end up increasing the dose of insulin. So the best way of managing, especially type 2 diabetes, is to increase the sensitivity of the receptors to the insulin, which is being blocked by the oxidative stress. And so we need to find out all the leakage of the free radicals, all the sources of free radicals, and manage them. So if you have leaky gut syndrome, leaking lipopolysaccharides, those liposaccharides, it's a free radical generator. It will cause oxidative stress to the body, and it causes oxidation of insulin receptors and causing what we call the insulin resistance. So we need to manage that. If the patient has Lyme disease, we need to manage that because that can be a source of infection. Patient has toxins, we need to detox the body. So all the sources of the inflammation, oxidative stress, it needs to be navigated and managed so that we can reduce those pathological free radicals that's causing the insulin resistance. So that's the difference between us and between the mainstream medicine. And yes, we still continue using the protocol of mainstream. We're still giving insulin, but we're trying to wean them as much as we can by improving the insulin sensitivity and manage the insulin resistance and all the causes and trigger of insulin resistance, which are any inflammatory conditions that affect any system. It needs to be addressed. And then, so that's why the Chronic Disease Prevention Management Group of American Medical Association, they say, well, in order to really find all those sources of free radicals and inflammation, we need to take from the patient a comprehensive history and physical exam. So it's not enough to just do one system and focus on one system. That's what the specialist does. We need to look at all the triggers of the inflammation, all the sources of free radicals that aggravate the condition that we are treating, and we need to navigate that, because if you navigate that, you're able to manage the patient. And so here, we do a comprehensive assessment, we uncover gut dysbiosis, and we see if the patient is being exposed to the toxins. We manage that, because all those are free radicals that lead to insulin resistance. And we look, patient maybe has rheumatoid arthritis. That rheumatoid arthritis generate free radicals, causing more of insulin resistance, and we need to manage that by modulating the immune system, not suppressing it with cortisone. Maybe when it's flare-up, you give them cortisone, but during the chronic status of the rheumatoid arthritis, we like to do immune modulation. So by implementing this personalized restoration or modulation of the immune, redox, metabolic, regenerative, the IR-MR strategy, our targeted measures such as, of course, dietary modification, probiotic, detoxification, all of this may help to navigate and manage all the sources of the free radicals, which leads to insulin resistance. And once we increase the sensitivity of insulin, to the insulin, we don't need much of insulin itself, right? And of course, that will help to improve the glycemic control and reduce the insulin need. So that's how we approach our patients. We combine both traditional and what we call it alternative or integrative approach together. Take both sides and be reasonable in managing your patient. So let's see here and look at what American Medical Association group, which is called the CDPM group, what they did and why they came up with this field of medicine, and definitely their focus is more in history and physical exam. They call it 360 HP. We extend beyond that, and our focus is more on diagnosis and treatment, but I did adapt their 360 HP as well in our management protocols. So let's go ahead and watch 5 minutes about what the CDPM group of AMA is talking about managing chronic diseases.
It's been known for decades that the biomedical picture is not the complete picture of the patient, and that became more and more clear as chronic diseases go undertreated or undermanaged.
60% of Americans have one chronic disease and 40% have more than two chronic diseases. And the traditional history and physical is really geared toward a single problem. And the HNP 360 allows us to really understand their chronic disease in the context of their social structure, their community structure, racial barriers that we need to consider if we're going to provide complete care for our patients.
So we have to find a way how to standardize it and actually come up with a tool to be able to collect their information in a strategic way. And the HNP 360 does exactly that.
Everywhere you want to take a picture of an entire patient and their life and their trajectory, these 7 areas pop up. They're both universal in that they apply to every patient in every context, and they're comprehensive.
It's a lot of information, but you don't have to use all of the domains all of the time. So you can kind of go and pick out the ones that are important.
These domains are flexible enough to allow assessment of these things that are so important to health, but in a very patient-centered way.
One of the domains that I really like is the patient values and goals domain, because it really helps me to understand where the patient is coming from.
Knowing that enables us to come up with a care plan that makes sense for them and is more likely to be executed well.
The mental health domain reminds us to ask patients what their day-to-day mood is like, things that might impact how they're able to manage their health conditions.
If I have somebody who has diabetes and I haven't delved into their depression, that's a barrier to self-care. So the HNP 360 is a tool to enable you to really see the patient for not just their biomedical condition, but beyond that.
And I think that by making it systematic, yet still flexible, you can catch things that would have gone unnoticed.
When you teach the students this from the beginning, then all the tools are there.
The HNP 360 has been tested and used in numerous different settings: inpatient, the outpatient, household-centered care, and telehealth. And it has been found to be helpful by both faculty and students alike.
It was like lights were going off. It gave them a way to navigate this complicated roadmap.
They learn more about their patients. Their patients feel that their physician or their student is very engaged in what's going on. So we have implemented this into our clinical skills curriculum. And this is the only history and physical that we're teaching.
It develops a common language for educators to start talking with their students about critical domains and gives educators a better sense of being kind of comprehensive with their patients. So at the end of the day, the HNP 360 is designed to be a simple roadmap and reminder to busy clinicians about the different aspects of patients' lives that ultimately determine not just their health outcomes, but the outcomes of their communities as a whole.
Okay, so that's the side of the CDPM group of the American Medical Association, and we extend beyond that and we say we need to redefine the history, the diagnosis and treatment, and we need to approach chronic disease by assessing, monitoring, and modulating the redox, metabolic, immune, and regenerative status of the patient. And we know that, this field of medicine, sometimes they call it integrative, holistic, regenerative. It's really a wild horse kind of everybody is coming up with his own protocol and own way of managing chronic disease integratively. And they call themselves integrative, holistic, regenerative. I use the word or the title of chronic disease prevention management because that's the system here, the health system. They like that kind of title where the doctors are determining exactly what they are treating. They don't want you to label yourself of how you're treating conditions, it seems like. But this is what AMA is entertaining in their website. They're asking us to develop residency, fellowship program, and structure this field of medicine. So I came up with a fellowship program. I'm doing my weekly webinars, and I'm attending a lot of conferences to present chronic disease prevention management and structure this field of medicine, which is not, it's just completely random, and there is no organization or structure in the protocols, or there's no really reference of textbook. That's I end up writing a textbook. I have a textbook for chronic disease prevention management, which is going to be published soon, and I will share it with you as well. So I end up with this fellowship program. It's approved by, the curriculum is approved by American Medical Association. We provide CME for it. And definitely it does help to give the doctors the tool that they need to master patients with complicated cases. And it's divided, the education is divided into 15 modules, and we're going to go through each one of those modules. Okay, so module number 1 is what exactly that HP 360 it's all about. That's what the group of the CDPM group of the American Medical Association is entertaining, is to take the comprehensive history and physical exam, including all the systems, including all the socio-economic stresses of the patients, and find out all the sources of free radicals and inflammation, and navigate it with when you're doing the management. So this module focuses on thorough evaluation utilizing tools such as HP 360 template. This tool aims to offer a comprehensive perspective on patients' health, taking into account various elements like medical history, lifestyle, choice, and environmental factors. And by employing these tools, healthcare profession can better comprehend the root causes. That's what we're doing. We're focusing more on the root cause of chronic illness and create tailored treatment plans, personalized plan that cater to the specific needs of each patient. And this methodology not only enhance the patient outcome, but also it elevate the overall quality of care. So let's give an example. We have a case, 60 years old woman, experience hypertension and persistent fatigue, undergoes an in-depth assessment, including genetic analysis, endothelial function evaluation, and the result indicates significant oxidative stress burden and autonomic dysfunction, and the treatment strategy that include antioxidant modulation of the autonomic nervous system, such as vagus nerve stimulation, lifestyle modification, led to substantial improvement in her symptoms and decrease her blood pressure. So in the mainstream medicine, we just give them medication that vasodilate the blood vessels and lower the blood pressure. We're looking for how we can improve the endothelial function test, how we can improve the endothelial cells function, because they secrete nitric oxide, and nitric oxide does the vasodilation that we're looking for. And so we go and see, okay, what is the cause of endothelial dysfunction? Why the endothelial is dysfunction? Because when it's being dysfunctional, it's not working, they don't produce nitric oxide, you end up with constriction, you end up with hypertension. So that's the root cause. And instead of just giving a medication to just dilate the blood vessels, we look at improving the endothelial function to secrete nitric oxide to vasodilate. So it's more about restoring the function of the body that's being affected by the oxidative stress, because the endothelial function of endothelial cells is very sensitive to the free radicals that is coming from, for example, your leaky gut, from the toxins your patients has, from conditioned diabetic patients, for example, they have a lot of glucose and they turn into glycans, and that can cause damage to the blood vessel, to atherosclerosis. We look at those things and we're trying to navigate those free radical generators by giving them antioxidants, by giving them light therapy, by giving them even nitric oxide itself. and to improve the endothelial function. And that leads to improving the blood pressure instead of just giving them the blood pressure medications, which has side effects. And eventually, we will wean down the blood medication once the blood pressure is being improved by just improving the endothelial function. So we look at the root cause and we fix the root cause, looking what caused the damage in the endothelial cells and fix that problem. And then we monitored the efficacy of the treatment using what we call the endothelial function test. I don't know about the endothelial function test. You hear about it. It's just a little probe in the finger, and the cuff will, it's the blood pressure that will cuff, that will press on the blood vessels. And then when you reopen it, it will lead to refilling of the capillaries. And then the system, there's an infrared camera, will detect how is the refilling is normal or not. If it's abnormal, that's mean the blood vessels is rigid, it's not compliant, and that's mean we need to work on making those blood vessels compliant by improving the endothelial cells function. Okay, so that's module number 1. Basically, it's just adapting the HP 360 of the chronic disease prevention management group of the AMA. Module number 2 is to see the gut health. It's very important. I think yesterday Dr. William Clearfield did have a very good, interesting presentation about the microbiome and how to restore the microbiome normality. And it's very important because if we have abnormal gut microbiome and we have pathological bacteria inside the gut, those pathological bacteria, those pathogens, they can break the barrier, allowing the leakage of lipopolysaccharides, and liposaccharides is a free radical generators. And those free radical generators will aggravate and trigger any underlying conditions. If the patient has diabetic, they become more, the insulin resistance become more worse because of the oxidation of their receptors of the insulin, and they will have insulin resistance more. And so managing the gut microbiome and restoring the normality of it and sealing those leakage of those lipopolysaccharides, it's the way to go to manage patients with diabetes if they have dysbiosis. And so the approach, as Dr. William yesterday is talking about, you start giving them prebiotic and possibly postbiotics, and also a probiotic itself. And we know the difference between prebiotic, probiotic, and postbiotics, right? Prebiotics is like hyaluronic acid, like aloe vera, where it feeds in the good microbiome and it kills the bad microbiome or bad bacteria. And then we have, this is the prebiotic. Probiotic is the microbiome itself or the bacteria itself. And the postbiotics is what the bacteria secretes, which is like butyric acid. And the butyric acid helps in decreasing the inflammation of the gut, which is mainly its Th17 dominance. And it helps to heal the tight junction of the gut epithelium. So this is the approach that we do. Or when we trying to manage irritable bowel syndrome. The mainstream medicine, what they do in irritable, did you see the drugs? It's horrible. They all neuroleptic drugs, trying to sedate the irritation and the neurons and numb them. That's what they do in mainstream medicine. But we look at the root cause of irritable bowel syndrome, and we think that leaky gut syndrome is one of the causes of irritable bowel syndrome, because when you have bad microbiome in the gut and you have leakage of the free radicals, what will happen? It leads to inflammation of the gut, and that will sensitize all the pain signaling of the gut itself, and chronic irritation of those pain signal leads to what we call hypertrophic in their pathways, and it leads eventually into overactive bowel as a reflex. Similar to complex regional pain syndrome, by the way. And then those free radicals, they go to the brain, and they cause inflammation, and the barrier of the brain-gut-brain, the blood-brain barrier will be defected and causing more pathogens to go into the brain, and it causes some sort of oxidative stress in the brain, and that itself will lead to abnormal autonomic nervous system function. In addition, those free radicals can damage the peripheral neuropathy as well, autonomic neuropathy leading to farther irritability of the bowel, because when your autonomic nervous system, they don't function well, your sympathetic and parasympathetic is overactive in some way, where you have patients have constipation, dominant irritable bowel syndrome, or your parasympathetic is overactive, and that leads to the diarrhea, dominant irritable bowel syndrome. And what they do, they just give you anti-diarrhea drugs or laxative to manage those symptoms. But what we do is to look at the root cause. And the root cause here, we think it's the free radicals that's being generated from the leaky gut. And possibly patient has toxin, fungus, any other things that may irritate the bowel. And when you constantly irritate the bowel, you end up with hypertrophic neuroplasticity change, we call hypertrophic neuroplastic change, of the whole pathway of the sensory and the response or the motor of the bowel, which is autonomic. And that leads to whole irritable bowel syndrome. It could be dominancy is constipation. Some of them are diarrhea type. Some of them are mixed between diarrhea and constipation. So what we need to do with these patients, we need to look at their stool and see the quality of the stool, the color, and the smell, and if it's floating or not. That means the patient have indication of a leaky gut syndrome. And then we may do some testing, finding out what's the pathogens there, and then we start introducing them prebiotics and postbiotics. I like to start with prebiotic for 1 week to kill all those bad bugs first, and then I will introduce them to probiotics and the postbiotics. But Dr. William yesterday, he did a very good job in this field of gut and health, and I think you can refer to his lecture. Now, module number 3, finished from 1, which is HP 360, 2 is gut, 3 is the integrative immunotherapy. Now, I will go back to my story about what led me to use immune modulation in managing chronic diseases. When I worked in Baylor College with Dr. Frank Arson, this is in 2005, I think, I used to see patients, and then he said, hey, I have a lab, and we want to do some immunotherapy. Let's come and do it. And so I ended up joining his lab. And what he does, he's an immunologist, and he wants to manage the root cause of allergy. So he doesn't want to just give them Benadryl. And so he's taking cases of peanut butter. You know, those people have allergy to peanut butter, peanuts. And he takes the protein, and then he translates it into a plasmid of DNA. And that plasmid of DNA, which is expressing the protein of the peanuts, he loads them inside dendritic cells. He takes the blood from the rat, spin it, take the white blood cells, monocytes, and then he treats them, become dendritic cells. And then he loads them with those plasmid that express the peanuts protein. And what would happen when the macrophages eats those plasmid, the plasmid starts expressing those protein of the peanuts, the macrophages polarize from naive macrophages into M1, and M1 will polarize the immune system, the naive TH, into TH1, and they will secrete cytokines. That will inhibit the cytokines of the TH2, which leads to allergies. So when we are exposing to peanut butter, and let's say, for example, I have allergy to peanut butter, and I expose to those protein, macrophages eats them, and they end up polarize into M2, and then M2 will secrete cytokines that polarize the immune system to TH2, and then that leads to a lot of interleukin-4 and activation of the basophils and the mast cells and immunoglobulin E, and causing all the manifestation of the allergy by releasing those histamine. So what he does is say, oh, well, if I introduce the plasmid and I express the protein in the macrophages will polarize to M1 in a state of M2, and that will lead to release of cytokines. Those cytokines will inhibit the cytokines of the TH2 and prevent that excessive hyperinflammation, hyperpolarization to TH1. So he's trying to shift the immune system from TH2 to TH1, from excessive M2 response into M1, and that leads to balance of the immune system. So that's how we manage allergy now. We desensitize the body by introducing the plasmid inside the cells where they will polarize in a different direction. If the macrophage take the protein from outside, they polarize it to M2, but if they are being expressed from inside, they polarize into M1. So he is trying to shift the immune system from Th2 to Th1. That's what we do when we treat allergies. And when we're treating autoimmune diseases like rheumatoid arthritis, that's Th1 dominance, and Th17, we're trying to shift them back to Treg and Th17. So that's what triggered me about using this immune modulation as one of the pillars of managing chronic diseases. So if I have any chronic diseases, I will look, is it Th1 dominant? Is it Th2 dominant? Is Th17 dominant? Some of them, they have Th1, Th17 dominancy and like a hybrid, or Th2, Th17 hybrid. And those are very complicated cases, but eventually we can inhibit them and polarize them to the opposite direction. Yes?
How is it different from desensitization therapy?
It's the same concept. So basically, when you introduce the protein in the skin and repeatedly, it seems that the macrophages, the dendritic cells in the skin, do express and modulate into M1 and Th1, and that will help to inhibit the polarization to Th2 when you do it through the skin. But if you take it, if you swallow, if you eat it, the macrophage function differently. They polarize too much to Th2, especially talking about patient has genetic SNPs of allergy to the peanuts, and they hyperpolarize to Th2, and that leads to interleukin-4, excessive interleukin-4, and mast cell activation and allergic reactions in general. So that's what desensitization, chronically, you end up also moving, but he wants to do it in a way more effective, just by loading inside dendritic cells the plasmid, and then he injects the whole macrophages that's being polarized into M1 into the body, and that will help to train the immune system to produce a balanced immune system, or immune response, the state of hyperpolarized into Th2. Does that make sense?
Can you go into how you harvest the macrophages?
He takes the monocytes from the blood, and then he puts it in a culture, okay, and that has media, growth factors, and that helps to monocytes to differentiate to macrophages and then to the dendritic cells. Does that make sense? Yeah, it's very, he's very intelligent. And because of that training that I have with him, what I did with him, I say, well, let's do this. Let's load the plasmid inside red blood cells, right? And then inject the red blood cells back. And then the red blood cells will go to the macrophages in the spleen. And then the macrophage will eat those red blood cells, right, that's being given. And that will polarize the immune system into Th1. So he said, okay, that's fine. Just go ahead. I have rats in the basement. Take the blood, spin it, get the red blood cells, and start loading it with plasmid that's fluorescent. I do that every day in the morning. I go to the basement, instead of seeing patients, seeing rats, get the blood out of them, go up, spin it, get the red blood cells, loading it with plasmid, fluorescent, and then I do just vortex it, and then I see them under the microscope, and I can see fluorescent. But the problem with this technique, it's good for drugs that's low molecular, but when it comes into big plasmid, it causes a lot of hemolysis. So it is not, it's a failure, right? But the failure lead to the success. And even Dr. Frank, he told me, failure is a success, because now we know this method doesn't work. So don't worry, don't get depressed. We will figure out the other ways. And then I end up moving forward with back to my clinical work. And I start thinking about how I can, do something about loading. And then I start using platelets. I say, well, let's do the platelets. Maybe platelets are good. Then I saw some articles about platelets nanoparticles. And I start, loading drugs inside platelets, nanoparticles. We call it targeted therapy. And I came up with a whole methodology of loading it, and I'm training doctors to do it in their clinics. And this will lead to load chemotherapy into platelet nanoparticles, so the chemotherapy does not go everywhere. It goes only to the cancer, because the cancer has leaky blood vessels, and those nanoparticles, when you are loading it with chemotherapy, they prefer to go to the leakage area because the size is up to 100 nanometer. They cannot seep into the healthy tissue blood vessels because they're tight. They go to the inflamed cancer pathology tissue. And also the platelet itself has receptors that has a tendency to actively attach to cancer, inflammasomes, senescent cells, and inflammation. And so I start looking at, is anybody did the same thing? And I find out that a big pharma company in California, they are doing the same thing. And they are loading drugs, antibodies, RNAs inside platelet nanoparticle. And you can search it in the internet. You will find a company based in California. It's called Therapeutic. And they have lots of publications. And I was very excited, but I was doing it in a clinical instead of waiting for them to mass produce it. In the future, maybe 10 years of now, all the drugs will be loaded inside platelet nanoparticles, especially the chemotherapy drugs. And so that, and also the antibodies, the immunotherapy, because one of the problem of the immuno-oncologists, when they give those antibodies, the anti-PD-L1 and anti-CTL4, yes, it helps to activate the immune system against the cancer and move the Tregs and inhibit the Tregs and shift the immune system to Th1 and cytotoxic T cells. But at the same time, it causes autoimmune diseases, right? Because it will trigger the immune system to attach and attack your own body. So they end up with a lot of side effect, which is colitis and inflammatory or autoimmune diseases. So loading those antibodies into platelet nanoparticle is the way to go. And I did train a lot of doctors, like maybe 10 doctors, and I'm trying to add more and training them, because once they train and they start doing it, everybody's doing. I mean, they will be doing it for all their conditions, especially when it comes into cancer. Even when you have osteoarthritis, you can load the platelets with your peptides and even loading it with cortisone if you want, and vitamins and all that, and you can inject them into the joint. So you can have that cocktail of drugs. And the platelets will allow this drug to slowly release, so you have less long-term effect. And also, it has the tendency to attach to the pathology and to the inflammasomes and senescent cells and cancer cells and things like that. In the joints, we want those platelets to attach to the inflammasomes and release those drugs into the area of the damage. So going back to module number 3, so we give a case here, 28-year-old women with chronic eczema and asthma undergo allergic testing revealing sensitivity to common food items and dust mites. Immunotherapy and desensitization therapy reduce their symptoms. Whether you're going to do it with the skin, poking the skin, right, with that allergens, or you want to use the technology of taking allergens and turn it into RNA and load them inside the dendritic cells and then infuse them inside. But we can use platelet nanoparticle now. We can load them with the RNA that express those proteins, and same thing with like COVID vaccine thing. They use RNA technology. And I'm not against the RNA technology, by the way. I'm against that the RNA, when you do the vaccine, it needs to be immunogenic and non-pathologic. But if it's immunogenic and pathologic, then I have a problem with that vaccine. As long as it's immunogenic and non-pathologic, then it's good. And I am with the RNA technology. But it has to be biodegradable, make sure there's nothing left, because if you inject them and the mRNA is expressing and limited, then it may lead to problems. Maybe those proteins will end up turning into prions and deposit into the brain, and that's what we don't want. Yes?
So when it's loaded through RNA, you're stuck only with protein. You can't really use any other molecules, right? And they're expressed on the surface of the cell. So medications, anything that is not protein would not be able to be immunologically recognized or expressed on the surface of the cell. That's what I'm trying to say.
Okay. You mean loading the platelet nanoparticle with drugs?
No, what I'm saying is if you're using RNA technology, loading any cell that is capable of producing protein and expressing it on the surface of the cell, you're stuck with proteins only.
Right, when you do RNAs.
Correct.
Yes.
And so when you talk about medications,
You can load medication inside the platelet nanoparticle. Any medication, any drugs, any antibodies, anything you want. I can load any injectable you have into platelet nanoparticle.
but that's cytoplasmically. It's not going to be expressed on the surface of the cell.
No, the purpose of loading drugs inside platelet nanoparticle is to carry the drug into the pathology. It's a delivery, target therapy. Does that make sense?
Does that mean that the cell has to lyse for those particles to be released, to be active?
Those platelets needs to
Yes.
be, yeah, when they reach to the target, they end up releasing those chemicals and they break down. And you can trigger that as well with light therapy, with laser, and increasing their concentration. Eventually, it will be degraded, and they will release their components into the pathology.
So why did it not work with the RBCs when they were lysing?
The problem with our RBC, because they're packed with hemoglobin. Now, I'm not talking about drugs. Drugs will work. But when the plasma is too big, and it will lead to hemolysis, and the hemoglobin is toxic to the body. Does that make sense?
Yeah.
So platelets is better than red blood cells when it comes into using big molecules. But small molecules, you can use red blood cells. And if you go to PubMeds and you say red blood cell loaded with drugs, you will find out a lot of articles. But when it comes into big proteins, and I prefer platelets. And I prefer platelets doing everything instead of red blood cells. I shift completely to platelets because I don't worry about hemolysis anymore and hemoglobin toxicity anymore. And that's what the future is, because there's a big pharma, they're already paying billions of dollars to come up with a mass production of those platelets nanoparticle loaded with immunotherapy and chemotherapy and all that stuff. But what they do also, before they load inside platelets nanoparticle, they stabilize the drug with PLGA, polymers, right? But okay, so my side, what I would do, I stabilize the drugs inside cyclodextrin. And that's another shift that I have, is I'm asking for the compounding pharmacy to load their drugs inside cyclodextrin. And I find one compounding pharmacy interested, it's called Strive Pharmacy, and they are loading all their drugs into cyclodextrin. And they have a technology, they spend millions of dollars because it requires a lot of extensive manufacturing process. But that's the future, loading drugs inside cyclodextrin, okay? And we're going to talk about cyclodextrin because I wrote a book on it. And cyclodextrin, it's the next trend of medicine. It's the next trend of medicine that we're going to use it for targeting therapy. And why cyclodextrin? Cyclodextrin can detox the body from fat-soluble toxins, from excess of oxidized cholesterol. It can go to the macrophages, the plaques, the foam macrophages that deposit the blood vessels, and collect all the cholesterol and clear the plaques. We don't have anything can do that, right? Statin cannot touch that, right? So clearing the blood vessels from plaques, I'm talking about. That's the miracle of cyclodextrin. And I wrote a book. It's actually, I have copies, 20 copies somewhere here. And you're going to have it if you stand in the, and I'll sign it for you. But it's the way to go. And plus, it will help to load drugs with anything you want, including antibodies, peptides, RNAs, and you can deliver the drug into the target. Now, can you say it's better to be the size of the nanoparticle up to 100 to get into the cancer versus going to the healthy tissue? Cyclodextrin does move the things into pathology, yes, but it's better if you clock them with platelets nanoparticles. So you increase their size into up to 100, and that leads to more into targeted into the cancer cells. But cyclodextrin-loaded drugs, it's better than naked drugs, especially peptides. When we give peptides, they degrade. So loading inside cyclodextrin will protect them and give them that long-term effect and change the pharmacokinetics there. So that's the book I wrote, and I have around 10 copies here. I'm going to give it for free for any doctors who wants it, right? So there we go. We use immunotherapy. We use desensitization therapy to reduce the hair symptoms in the stage of masking it. Additional cytokine testing, anti-inflammatory interventions, including omega-3 supplementation and dietary. So we want to give the patient all the supplements that will inhibit the Th2. right? And peptides. Let's say, what's the peptide that inhibit the Th2 and move it to Th1? Thymosin alpha, right? Thymosin alpha is a good thing for allergy, by the way. And anything you use for allergy is good for cancer. Because when we treat allergies, we inhibit the Th2 and Th17, because they have some active Th17 as well. And that leads to polarization of the immune system to Th1. And that's what you need in cancer, because you want Th1 and you need cytotoxic T cells to kill the cancer. Okay, and so we give all this medication. In allergy, there's Th2 components, and basophils and mast cells activation, but also there's some of Th17. So any supplements like omega-3 that inhibit the Th17, Metlam Blue also inhibit the Th17, will help the patient with allergies. So it's really a hybrid of both Th2 and Th17 about allergies. Okay, so module number 4. Now, if I did not finish, I have a 45 minutes after the break, after 3 p.m., and we can finish there. Okay, so don't worry about not finishing. So the module 4 is to detox the body from environmental toxins. As we know, we have a big burden of environmental toxins. We're living inside a bubble of petrochemicals, right? Plastics everywhere. Everything is around us plastic. And this microplastics, this fumes that's coming from the manufacturers, they are organophosphorus and all the petrochemical. Those are fat-soluble toxins, right? We've been exposed. Anything we can do for fat-soluble toxins? Do you know any chelation for fat-soluble toxins? Sweating, right? Yes, that's the book. He has it. That's the only thing we have, right? Now we have. Before we don't have. Before I was relying on the sweat glands to sweat those fat-soluble toxins. And now we have cyclodextrin, will do the detoxification of fat-soluble toxins, right? And also, do we have anything for mycotoxins? We sweat them. That's the only thing. We ask the patient to go to the sauna and sweat them. We don't have anything that will chelate mycotoxins. Now we have cyclodextrin. So, and there's companies already doing cyclodextrin loaded with antifungal drugs. The conazoles drugs, right? Itraconazoles and all those ones. The zoles, antifungals. They're loading cyclodextrin for both, for killing the fungus and also detoxing the body from the mycotoxins. And so that's part, because those toxins, they are a free radical generator. In order to restore the redox status of the patient, you need to detox the body from those toxins. So it's part of redox. One pillar of the chronic disease prevention is to restore redox. And detoxification using EDTA, and we can now develop EDTA, right? Those pharmacies, they can develop EDTA loaded with cyclodextrin. Why I want to do that? Because EDTA will take care of the water-soluble toxins, right? The minerals and water-soluble toxins. And then the cyclodextrin will take care of the fat-soluble toxins. So now we have a combination of both water-soluble and fat-soluble. And we can do very good in detoxing the body. So it's part of management of chronic disease is to restore the detox. Detoxing the body is part of it. 42 years old factory worker with chronic fatigue, neuropathy, is diagnosed with heavy metal toxicity. So what we do chelation therapy. And if this worker also has been exposed to fat-soluble toxins in the factory, the cyclodextrin will take care of that. And then when you do detoxification, sometimes you deplete with nutrition and minerals. So I recommend what you do, Meyer cocktail, multivitamins, right, IVs. And those compounding pharmacy, they have that. So this is the module number 4. See, I'm trying to structure this field of medicines called integrative, holistic, homeopathic, regenerative, right? And putting under one big umbrella that's called chronic disease prevention management, right? And present it to the mainstream medicine and get the mainstream medicine on the board with us. Okay, still have 8 minutes. Again, don't worry if I did not finish. I have 15 modules. We still have, I have 1 hour maybe after the break. What are the things that we have a concern or can be a source of free radicals and aggravate the underlying chronic diseases that we are treating is chronic infection. What will be the chronic infection? Lyme, Epstein-Barr virus, right? There's clinics. I hear some doctors, they open up the clinic for Lyme disease. Yeah, so we need to figure out if those patients, especially with your history, see the comprehensive HP 360 is very important, so you can ask for those questions. And you don't narrow yourself with one system. You need to look at all the factors that trigger and cause oxidative stress. And if we see in the history how the patient may be hunting, or the patients maybe have multiple partners and things like that, could be has sexual transmitted disease or being exposed. So all those chronic infection that needs to be screened out. And there is a big company, I don't want to give the name of it, but they do lymphocyte mapping, cytokine profile, and also they do chronic infection panels. So they give you all the panels of chronic infection, Lyme, Epstein-Barr virus, name them, fungus infection and all that stuff. And then if you find out they're positive, what you would do? You're trying to manage them. What's the best management for chronic infection? Anybody knows? In general, we can use one thing or two things. Methylene blue, you give them IV, and you put them in a bed of red light and ozone, and it will take care of most of those pathogens, right? It's called methylene blue photodynamic therapy. Methylene blue is one of the drugs that I put a lot of emphasis on it in our education to manage even COVID. And there was all the compounding pharmacies, they start doing methylene blue for chronic infection, along with photodynamic therapy, light, along with ozone. Very important to combine them. So you generate enough free radicals to kill those bugs. Because antibiotics, sometimes they get resistance to it, antiviral also, but methylene blue, and you load them with cyclodextrin, right? Then you give them either IV or oral, and then you put them in the bed with light and ozone, and you end up destroying much of those infection. And then you monitor the efficacy by doing another chronic disease panel and see if you're able to mitigate that. And loading with cyclodextrin also, it has an antibiotic effect. It does damage the virus and bacteria as well. So you have the methylene blue and cyclodextrin. Yes, cyclodextrin is carrier, but also it has a very powerful broad-spectrum antibiotic effect. But you can use antibiotics if you want and other antifungals and all those things, but in case they are resistant to it, just use methylene blue for the dynamic therapy and with the ozone and you'll do good. And when you have chronic inflammation, you have, especially with bacteria, you have too much of Th17 overactive, right? So you may need to give them some immune modulation drugs like naltrexone to calm the inflammation down. And that's what we do as integrative doctors. We're not negating not giving antibiotics, we will, but if we can do it at the same time, do other things, especially if they have resistance to it, and also work on the inflammation, because the damage that's happening from those infections also is because of inducing too much of inflammation that can damage the body and trigger autoimmune diseases, Lyme, and so we need to put the inflammation down, and naltrexone will be one of the drugs that we think is a good thing to do. Module number 6 is to normalize all your chemistry of your body. So when I say metabolic, I'm not meaning metabolic syndrome, just normalizing your sugar and cholesterol and decreasing weight. Those are metabolic syndrome, obesity, diabetic hypertension, and hypercholesterolemia. No, I'm talking about restoring the whole metabolism of the body, all the chemical reactions, including 6 hormones, restoring 6 hormones, restoring minerals, the vitamins, whatever deficient you have. This is under the metabolic, right? So restoring, optimizing the metabolism of the body. And a case here, 50 years old man with metabolic syndrome. Metabolic syndrome is part of it, but it's not everything, right? With personalized nutrition and counseling and bioidentical hormone therapy. So again, it's not just, and we can give them, if they are obese, we can give them GLP-1s, right? Now GLP-1s, we can load them inside cyclodextrin. What's the better, why we load them inside cyclodextrin? It will enhance the efficacy. Because when you give them GLP-1, they lose appetite and they shrink the fat. What will happen to the toxins from the fat that's being stored? They release out and they can cause organ failure or they can cause inflammation, right? And so if you load them inside cyclodextrin will take care of all those toxins, the fat-soluble toxins that's being released from the fat tissue, and dump them into the bile or into the kidneys, and you get rid from it. So that's a new project that we can do, is to load the GLP-1 inside cyclodextrin. And then you can also, instead of injection, you can also do it oral and sublingual. And that's a project that I'm working on as well. Also 6 hormones, you can load them inside cyclodextrin, by the way. You can get better results. Any drugs. If you load with cyclodextrin, you end up with 5 to 10 times more effective. So I still have 2 minutes to go, but again, we have a break after this and we can finish it there. So his lab marker improved significantly, including reduced triglycerides and better insulin sensitivity. So very important is to look up all those free radical generators and navigate them. And if the patient has diabetic, you need to navigate that, especially with looking for all the sources of free radicals. Could be leaky gut, toxins, chronic infection. And that will help to increase the sensitivity of insulin, so you don't need to give much of insulin there. So it does not mean that we stop them from giving insulin and just give them nutrition. No, you still give them insulin, but you work on improving the insulin resistance by navigating, assessing the sources of the free radicals that cause oxidation of those receptors and cause them insensitive in the beginning. Okay, the module number, last module, which is cancer. I think I will let the cancer, because it's a very long topic, and I'm going to spend almost 15 minutes in it. Just show you that the cancer cannot be managed in one way. It's like an onion with many layers, and we need to peel those layers. And I will just give you a hint about what we're going to do and finish it next. You know, the cancer, it's not just destroying the cancer itself with chemotherapy and radiotherapy. That's the mainstream medicine focus. It's all about cancer itself. They're going to destroy it. Now, they also need to change the tumor microenvironment. The tumor microenvironment is it's in favor of the cancer. So the cancer is very intelligent, right? They start secreting chemicals to polarize your immune system from Th1 to Th2 and Th17. So you don't have much of cytotoxic T cells to kill them. What do you have? You have neutrophil, mast cells. What they will do? Nothing to the cancer. You need cytotoxic T cells. So the cancer starts secreting, transforming growth factor beta and all the chemicals that polarize the immune system away from Th1. Okay? And then they also polarize the immune system to Tregs, and your immune system, instead of destroying the cancer, they're defending the cancer. They form a shield around it. So how we manage that is to polarize the immune system to Th1. The cancer also secretes chemicals that leads to fibrosis and squeeze the blood vessels, preventing lymphocyte infiltration, right? So you need to give them antifibrotic. They have platelets, and they surround themselves with the platelets, forming a shield around them. So you need to give them antiplatelets. The cancer also blocks the mitochondria and rely on glycolysis as energy. Why they block the mitochondria? Because the mitochondria is a bomb. And if they allow it to be active, it will cause mitophagy and blow up the cancer. So that's why they stop the mitochondria. So how we manage it? Activate the mitochondria using polyphenols, using methylene blue, using resveratrol, using QQ10, and all that stuff. We're going to finish after the break, but if you have any questions.
So we're going to go ahead and move you forward, just so we got a big one here, and I think I have space for you in the classroom after this. So, but big round of applause for Dr. Halasa.